Okay, and welcome back to today's webinar, Laser Therapy for Rotator Cuff Tendinopathies. My name is Dr. David Kanashko. I'm a chiropractor and I'm the Director of Education and Training here in Toronto for Meditech and Bioflex Laser Therapy. Before we get started, I just wanted to let you know that there will be time for questions at the end of the webinar. So just type them in as you go along and I'll address those questions at the very end. Also, the webinar is being recorded and I always get emails asking about when it can be viewed again. Usually within a week or so, the webinar is actually posted on our support page. So that's a Bioflex user portal that you have to have a username and password in order to access. Other than that, I think we'll get started. So what I'd like to do is do a little review of the anatomy and definition of a rotator cuff tendinopathy. This webinar gave me a chance to review the latest research and anatomy with respect to this condition, and hopefully you'll find it a little bit enlightening, especially from what you perhaps were taught in school over the last 5, 10, 15, or in my case, 25 years ago. I'll also talk a bit about the etiology, pathogenesis, assessment, and treatment of this condition. Again, it might be a little bit eye-opening with respect to this. And then a couple of research papers on LLOT, photobiomodulation, and shoulder rotator cuff tendinopathy. Then I'll discuss how we approach treating this condition with our equipment. And lastly, a case study I'll present as well. And then we'll have some time, as I mentioned, for some Q&A. So as you all know, the rotator cuff consists of 4 muscle groups: the subscapularis, infraspinatus, supraspinatus, and teres minor, or the sits muscles as we have come to know them. They originate from the scapula and insert into the lesser and greater tubercles of the humerus. The tendons, of course, cross the shoulder joint and blend with each other and the joint capsule. So if you look at some diagrams here, in the first diagram, an anterior view with the subscapularis attaching to the tubercle, and you can see the infraspinatus in the back, and of course an anterior or a posterior view showing you the infraspinatus muscle, teres minor muscle, and supraspinatus. And you can see how they start to form and blend into a capsule, into the capsule and the tendon as it inserts into the tubercle of the humerus. Also be aware that these tendons start to flatten out as they make that common tendon at the insertion point. So they become a lot less sort of thinner, not as robust as they actually attach to the bone. So those are your sits muscles. Everyone knows them quite well. These muscles help to stabilize the glenohumeral joint, and they help with abduction, internal rotation, and external rotation. So I want to point to the fact that these aid in these movements. They're not the sole muscles that cause these movements, which in itself is problematic when we go to test for these specific muscles and may have a difficult time in isolating them. I'll talk more about that shortly. So rotator cuff tendinopathy is probably one of the most common causes of shoulder pain. The rotator cuff tendons, particularly the supraspinatus, as you know, are uniquely susceptible to compressive forces of the subacromial impingement. forces of subacromial impingement, and oftentimes you'll hear that phrase subacromial impingement, and really it's basically referring to a rotator cuff tendinopathy. So they really are pretty much the same thing. Improper athletic technique, poor posture, poor conditioning, failure of the subacromial bursa to protect the tendons. These can all cause issues, and there can be calcification, degenerative thinning, and these can all lead to eventual tendon tears as we age. So that tends to be the most common sort of etiology. The rest of the information I've taken from an article you can see at the bottom here by Haslard S. al. From a physiotherapy journal. Rotator cuff disorders are by far the most common problem affecting the shoulder complex. According to this research paper, it accounts for nearly 2/3 of all shoulder cases being presented to primary healthcare practitioners. Rotator cuff tendinopathy is commonly referred to, as I mentioned, subacromial impingement syndrome. So they're really one and the same, although sometimes you'll also hear about bicipital tendinitis or tendinopathy thrown in with that subacromial impingement syndrome as well. It's believed that the acromial irritation is not the primary cause of symptoms. According to this paper, only 50% of all patients diagnosed with rotator cuff tendinopathy seem to be fully recovered within the first 12 months. This indicates that it's an absence of a self-limiting disease course, which means that we need to develop an effective treatment program. So in other words, the majority of patients that have this proper diagnosis, it takes a long time for them to get better, and oftentimes it doesn't get better. So that you should be aware of that when patients present to you, and the time frame it might take for them to get better, even with treatment. And that's really important for you to be successful with what you're trying to accomplish. So the hallmark characteristics of rotator cuff tendinopathy are, of course, pain and weakness, and most commonly with shoulder external rotation and elevation as a consequence of excessive loading of the rotator cuff tissues. So assessment is complicated by non-specific clinical tests and the poor correlation between structural failure and symptoms. So I've actually I've learned that many of these tests that we were basically instructed on to use to make these diagnoses and sort of verify what's going on in the shoulder, oftentimes they don't necessarily correlate very well with symptoms that the patient might be having. The principles guiding treatment for this type of condition include, obviously, you want to make the patient have appropriate rest. You need to have them modify painful activities. Exercise is really critical in helping these patients recover, so make sure that you understand how to properly address the condition and appropriately when exercises should be done. Controlled reloading and a very gradual progression from simple to complex shoulder movements. This is really important because you don't want to overdo the stress and compression on these tissues. So the definitive cause of this tendinopathy still remains uncertain, even in current research. There's relatively poor understanding of the source of pain in rotator cuff tendinopathy as well. So they still really struggle with the exact etiology and what's causing the pain in these patients. That's why sometimes it's very challenging or difficult to get these patients better, because there may be something else going on as well. Some of the proposed mechanisms, they talk about intrinsic and extrinsic, as well as combined intrinsic-extrinsic mechanisms. So for example, extrinsic mechanisms would include reducing the strength of the tendons due to contact with structures against the humeral head, poor functioning of the musculature, fatigue, pain-related inhibition, structural incompetence, for example, reduction of the subacromial space. Those are the common extrinsic factors. Intrinsically, you're looking at mechanisms that directly influence the tendon health and quality. So, for example, aging. We know that many patients, especially as they get in their 60s, 70s, and 80s, if you were to take an MRI of their rotator cuff tendon, you would find a very large percentage of them that have rotator cuff tendinopathy or tears, yet many of them may be asymptomatic. And so you need to keep that in mind. Genetics, vascular changes, altered loading patterns, these are all perhaps intrinsic mechanisms. Excessive tissue load remains the most common factor in the development of rotator cuff tendinopathy, and this is reflected by the fact that this condition occurs much more frequently in the dominant limb and in occupations and sports with high rates of upper limb loading. So think of a baseball pitcher or someone that is right or left dominant and doing different types of occupations that will load up and stress the rotator cuff tendon. So under loading, this may also disrupt the tendon homeostasis, which potentially results in a temporarily earlier point of failure when the tendon is subject to load. So the other factors you need to consider are lifestyle factors, obesity, metabolic syndromes, smoking. They can all increase the risk and have a detrimental impact on the recovery of these patients. So you need to address these concerns as well when you're treating your patient. A significant proportion of individuals with rotator cuff tendinopathy have pain that radiates down the arm, and even they have hyperalgesia to pinprick stimulus of the skin. So this suggests, in fact, that there might be a central sensitization that's present in a proportion of people that do have a diagnosis with rotator cuff tendinopathy, and that the pain experience may not always relate to the local pathology. So in other words, you need to look at the cervical spine for some of these patients. So when you're checking out the shoulder and you're not maybe quite sure what's going on, you should always take a look at the neck, maybe get some imaging as well, and think that there might be a chronic pain syndrome going on, also involving the cervical spine. So be aware of this when you're treating these patients. It might be helpful, especially if you're not getting anywhere treating directly on the shoulder. Special orthopedic tests that we were all taught back in the day. Essentially, we were told they were designed to assess the structural integrity of the rotator cuff. So that, these tests are designed to reproduce the pain, identify the weakness during these procedures, so that it's considered clinically diagnostic. However, recent multiple narrative and systematic reviews have concluded that the ability of these tests to implicate the rotator cuff as a source of the symptoms cannot be achieved with certainty and confidence. So the inability to test shoulder muscles in isolation is one of the main issues. So they've done intramuscular EMG studies, and they've compared the full empty can tests. These are the most common tests that are done to check for supraspinatus pathologies. And during the full can test, 8 other shoulder muscles other than the supraspinatus were equally activated, while the empty can test, 9 other shoulder muscles were equally activated as well. So this obviously challenges the validity and clinical utility of these tests. So bear that in mind when you're checking these patients out, that it may not necessarily be 100% conclusive just based on orthopedic testing. The authors of several imaging studies have reported the presence of substantial shoulder tissue structural abnormalities in people without shoulder symptoms. So these imaging studies highlight the fact that many people undergo surgery on shoulder tissues that potentially may not actually need that surgery. In other words, even though they have MRI imaging to show an issue with the rotator cuff tendon, that may not actually be the cause of their symptoms. So that's also important if a patient may be considering surgery as a last-ditch effort. So asymptomatic partial and full thickness rotator cuff tears have been reported in 50% of people in their 7th decade and 80% of people in patients over 80 years of age. So that's asymptomatic. These people have tears, sometimes even quite large tears, yet they're asymptomatic. So again, just because the patient has tearing, be aware of the age of the patient as well. So current research evidence provides considerable confidence for people diagnosed with rotator cuff tendinopathy to expect an equivalent outcome to surgical intervention with a well-structured and graduated exercise program. And I'm also going to add laser therapy as far as what we feel will be very helpful in recovery. They also know that glucocorticoid and analgesics have been shown to actually reduce tenocyte proliferation that may be a feature of irritable rotator cuff tendinopathy. So in other words, glucocorticoids and analgesics may actually not be recommended and probably shouldn't be used in these conditions. Let's look at some of the research with respect to LLOT and rotator cuff tendinopathies. This one was published in 2015, entitled The Efficacy of LLOT for Shoulder Tendinopathy, a Systematic Review and Meta-Analysis of RCTs. So this is your, the highest gold standard with respect to evidence-based research. They looked at pain relief using a VAS scale, 100 millimeter, as well as relative risk for global improvement. They had 17 randomized control trials that they used that they could include in their criteria. And the results of the study showed that LLOT reduces pain and accelerates improvement when used as a monotherapy or as an add-on therapy to exercise or in a physiotherapy treatment regime. So really the evidence speaks a lot to using LLOT either on its own, but preferably with a good exercise regime when warranted, and you'll have better overall effects. So except for LLOT alone, there is no strong evidence for an effect on shoulder function. So in other words, LLOT seems to have a much greater effect on shoulder function than exercise alone. So they concluded that this review shows that optimal LLOT can offer clinically relevant pain relief and initiate a more rapid course of improvement, either both alone or in combination with physiotherapy interventions. So their findings challenge the conclusions in previous multimodal shoulder reviews of physiotherapy and their lack of intervention quality assessments. This is a really great paper, not just because it's saying that LLOT works, but really dispelling the myth that these patients should only be undergoing exercise regimes. We know that by adding this type of therapy, it works in a different way and helps a lot with pain, the ability of the muscle and the tendon to repair itself, which you will assist with the exercise regime as well. Another paper done in 2011 was a randomized control trial looking at the additive effects of LLOT with exercises for subacromial syndrome. Basically, they diagnosed this as rotator cuff tendinopathy. They also added bicipital tendinopathy as well. And it was a randomized double-blinded control trial. They looked at 80 patients. They were all diagnosed with subacromial syndrome. 40 in group 1 received LLOT and exercise therapy, a total of 10 treatments over 2 weeks. And the second group had placebo placebo laser, and the same exercise therapy was given for the same treatment period. They used a wavelength of 890 nanometers, and in a pulsed mode. They did not say what pulse they used, which is always annoying, but so it was some kind of pulsation that I don't know what it was. In each treatment session, 3 points were used around the shoulder, including anteriorly around the coracoid process, posteriorly around the GH joint, and laterally around the rotator cuff tendon insertion. And each of these areas was irradiated for about 2 minutes for a total of 6 minutes in total treatment time. And the results were, they concluded that the study indicates that LLOT combined with exercise is more effective than exercise therapy alone in relieving pain and in improving shoulder joint range of motion in patients with subacromial syndrome. All right, well, let's look at what we do with our treatment. Everyone here that's listening that uses our equipment is familiar with our stages 1, 2, and 3 of our protocols. This is a rotator cuff tendinopathy protocol. The dual red is set at continuous wave, 3 placements that I'll show you shortly for 5 minutes in each side. And then we have a range of a frequency and duty cycle for the dual infrared, anywhere from 10-20. So you can see it's a fairly low frequency, and a sort of mid-level duty cycle anywhere from 40 to 80. And for 6 minutes, to reflect that we're trying to get a little bit deeper. And then using the laser diode infrared probe, continuous wave, we usually set it at around 30 or 40% initially for anywhere from 6 to 12 minutes, depending on how involved you feel you need to be. And then working our way up to stage 2 and then stage 3. I do want to let you know that when you first start off, the computer will start off with the lowest parameter. So we'll start with a 10 and a 40. That doesn't mean you have to start with a 10 and a 40. It means you can start maybe with a 20 and 50 or 60 or 70 and still be within that stage 1. If the patient is in a fair amount of pain, you feel there might be sensitive treatment, start with lower parameters, maybe 10, 40, even 10, 30. But if you feel that that's not the case, you can maybe start with a 20 hertz and maybe a 50 or 60 or even 80% duty cycle, but probably more around the 50 would be more adequate. Whereas in stage 2, you're going to be modulating the red, usually 190, and increasing the frequency up to 50, and keeping the duty cycle, at that higher level, 60 to 80% duty cycle. And then lastly, stage 3, which usually isn't used too often, especially in these shoulder conditions, but a much higher frequency and higher duty cycles, as you can see here. So those are the standard protocols that we tend to use for these conditions. The placements anteriorly, the idea here is you want to cover, over the bicipital tendons, over the anterior shoulder. You can see it will go on top and also start to treat around the supraspinatus muscle belly and the rotator cuff tendon to some degree. Laterally is where you get the bulk of the supraspinatus muscle and the insertion into the tubercle. If you look carefully, you can see the arm is at the side, but if you have the patient adduct their arm, you'll actually be able to bring out that tendon a little bit more and make it more exposed. So that's one thing that you can have the patient do is adduct their shoulder if possible to allow the light to get more at that tendon. And then posteriorly, wrapped around the back, here you're trying to get the teres minor, infraspinatus, supraspinatus, and again, a bit more of the rotator cuff tendon. So you do want to treat all the way around the shoulder joint, even though it's just a rotator cuff. There's so many structures involved here that you want to make sure you treat them appropriately. Some treatment points I might add is that, as I mentioned, you want to treat all the way around the shoulder joint. You might have to lower the frequency and our duty cycle if the patient is in significant pain. Obviously, you want to have a realistic expectation with respect to the recovery. As I mentioned in the review, that these patients tend not to get better quick. So don't have them think that a week or two and they'll be good to go, because that's just not realistic in most cases. Obviously, you're going to add manual therapy and exercises within patient tolerance levels, and when you feel it's adequate to add. What you don't want to do is exacerbate the problem by overzealous exercises, and that just sets them back typically. As I mentioned earlier as well, you might consider treating the cervical spine on the affected side. Make sure you treat proximal and distal trigger points that might be referring pain to the area. Remember that you're stimulating both an anti-inflammatory process and tissue regeneration. So this does take time to manifest as objective improvement by the patient. So treatment time, essentially with respect to using the laser probe, reflects the therapeutic dosage at the tendon depth. So in other words, you want to hold the probe anywhere from 5 to 8 seconds if you're right on top of the rotator cuff tendon, but I would increase that time to 10 to 15 seconds if you're treating the subscapularis tendon or deeper muscle tissues where you want to get that light to penetrate as deep as possible to have a positive effect. So again, you might want to treat, or you should treat, the axillary region for the subscapularis, both the muscle belly, but especially the insertion of the subscapularis tendon into the rotator cuff region. So once all the points are treated, it's kind of a good idea to go back to the common tendon and treat again with the laser probe. If you do have an LDR, that's the red laser probe, you should use that as well too. It's quite effective for helping with pain. As I mentioned, you can place the glenohumeral joint in different positions to try to expose the the rotator cuff tendon to treatment. So, for example, adduction will help expose the supraspinatus tendon a little bit more. So those are all some good tips, hopefully some things that you may not be aware of. Let's talk about a case study. This was a fairly young individual. That's important to understand. He was a personal trainer and having right shoulder issues. And notice how long it was going on for 18 months. And the severity was increasing over time. And obviously it was restricting his ability to use his right side. And he tried different therapies mainly having temporary relief, nothing long lasting. Tenderness, as you would expect, around the shoulder joint, including the deltoid, the biceps, supraspinatus, shoulder joint capsule, limited range of motion. Patient did have an ultrasound that indicated some calcific tendinopathy of the supraspinatus tendon, so obviously there's a pathology going on there, as well as some issues with the biceps tendon as well, tenosynovitis. So we do know that when you're dealing with the calcifications of the tendon, oftentimes it's really painful when the body starts to resorb the calcium. Not so much when the calcium is present, but more when the body is actually resorbing it. And that's when it tends to be the most painful. Our treatment plan laid out over a period of time. Initially we started off with 4 consecutive treatments, and then we went to 3 after the second week, and then 2 to 3 times into the third, fourth. I didn't show you the extension, but we treated the patient over a couple of months. And then we slowly added some manual therapies and exercises as the patient could tolerate it. So the first treatments, we looked at a continuous wave of the red, the 3 placements I mentioned earlier. The infrared was 20 hertz, 60% duty cycle. Again, this isn't the 1040 that the computer would have chosen. We customized it. We did slightly increase the frequency and duty cycle. We felt because of the patient's age being fairly young, maybe want to be a bit more aggressive to see if they could tolerate it. And in fact, he was able to without any negative effect. So that's what we did there. The probe was set to 40% initially for the first few sessions. And we used the red probe as well to help modulate pain. The remainder of the treatments was in the high stage 1 and beginning of stage 2. So we did alter the dual red. We used a pulse frequency of 100, a high duty cycle of 90%, and we kept the frequency still fairly low. We do find that shoulders tend to be a little bit sensitive to frequency, so we tend to keep them fairly low. That's something that you may find helpful. And we increased the duty cycle to 70% of full power, and the probe was used at 100% full power, as was the red probe as well. Notice that we used 10 minutes of total treatment time for the probe. There's a range in the protocol. I think it's from 6 to 12. So 10 minutes was adequate for us to get to all the tissues that we needed to. So patient had 15 treatments, and over a period of about 2 months. At that point, they were about 90% overall improvement. They were able to be medication-free, started to resume activities of daily living, and was starting to get back into his occupation as a personal trainer, albeit it was a modified duties for another month after that. And then we did recommend some maintenance laser therapy to still come in once a week to continue stimulation and to help that tendon deal with this calcification and inflammation around the tendon and tendons involved, and to help with tissue regeneration as well. So, we feel that laser therapy can be a very effective therapeutic approach for these types of injuries. Oftentimes they're related to sports in younger people and more an aging process or repetitive use in older people. And the use of laser therapy can help mitigate pain and inflammation, help with angiogenesis and collagen production and soft tissue repair. And this will help to minimize scar tissue and adhesions as that patient is trying to undergo rehabilitation. All right. Well, that is the webinar for today. I really very much appreciate you listening in. I will be listing the next several webinars next week in 2018. I hope everyone has a great holiday season and takes a bit of time off, perhaps with your family and friends. And let me see if we have any questions. So I have a few here. So a question is, I never understood at which point you move up to the next stage. What are the indicators that you would shift up a notch? The really indicators that we're looking at is lack of progression after a series of treatments. So in other words, if the patient seems to overall be improving, we usually keep the protocol the same, maybe slightly tweak it up. But it's when the patient finds that they're just not improving after 2 or 3 consecutive treatments is when we'll start to shift it up a notch or go to the next stage. Treatment frequency, I think I did address that. We're treating 2 to 3 times a week, especially until we get them out of the really acute phase or where we see a lot of progression going on. That's really important that they stick to that regime. Otherwise, you can go down to 1 to 2 times a week to kind of resolve it towards the end point. And another question is, with the red and infrared arrays, would it be useful to add a minute or 2 rather than increase the protocol hertz or duty cycle if there is a plateau in treatment improvement? It's not necessarily a dosage thing because if you were to increase the time of the arrays, you're increasing the dosaging. I would say that when they're plateauing, the cells and the tissues don't seem to be reacting in the same way. And it's not necessarily the dosaging. It has probably more to do with the frequency, that is the hertz or cycles per second, than anything else. So I wouldn't necessarily say that's the case. And will I be making my slides available post-lecture? These are all posted on our support page within a week or so of broadcast, unless you want to send me a check for $1,000 and I'll make them available right away. Do you use the preset parameters on the laser or the parameters that you presented customized? Again, I did show you some customized parameters. However, they're pretty similar to the standard parameters in the protocols in the software. And lastly, do you cover the same treatment areas with the red laser probe that you did with the infrared probe? That's a really good point. I would actually try to focus the red more around the areas of pain. Obviously, you can do that with the infrared probe as well too, but focus more on the areas of pain. So pain with point tenderness is where I would focus the red, because that's where you have more of an analgesic effect. Whereas with the infrared probe, you may even want to target some areas that maybe aren't as painful, but are involved with the pathology to stimulate the healing. All right, well, thanks again, everyone, for a great 2017. Had some really great turnout for the webinars, and hopefully you can all make it in and join me in January. Happy New Year, and have a good holiday. All right, so I'm going to stop. All right.
Nice. That's really a nice service. I mean, really, it is.
Yeah, I've been doing it for 2 years now. And so what we do in our basic training that I know you're here for is we'll go over all the basics. Mm-hmm. I can't spend an hour or half an hour on rotator cuff, right? There's just too many conditions. It's too expansive. This gives me the ability to focus in, and not just on laser, but you can say give a backdrop, right? Where the latest research is, refresher of the anatomy, refreshing, things have changed, as far as orthopedic testing for chiropractors and physiotherapists. Even sort of evidence-based guidelines now about corticosteroids, those kinds of things have changed. And for anyone that's been out 5, 10, 15, 25 years may not be aware of that kind of scenario. So I think it's helpful to do that. We get good feedback. Obviously anyone can listen in, but it's really meant to be archived and used by our practitioners at any given point, sort of later on. So
I mean, but all this is archived, so I could see some of the ones that
oh yeah.
Ones.
Oh yeah. There's
Very
20,
nice.
30, 40, 50 there.
Really?
Yeah.
Cool.
So yeah, it's really today was kind of a low turnout. I usually get 300 to 400 registering and about 150 to 200 listening in. but I think the time of the year and some other stuff, right? But still, for 50 people to take time out of their lunch to listen in, I think that's a good sign that people appreciate it. Not all of them would have our system. Some of them, most equipment you don't get any training, so people look to find more information wherever they can. But we feel it's really important to get properly trained and then have that support to be more effective, right?
So this is not just available to your users; it's available to other people also.
This broadcast was open; anyone could. Anyone could. We were thinking about adding as a paywall or just for our users. But to be honest, it's also very good. I wouldn't call it a marketing tool directly because you can see I don't market.
Right.
I'm not advertising for anything.
Right.
But what it does do is it makes people aware of what, as a company, we do, how we approach treatment.
Yeah.
Then, if you're in the market for it, well, you can see what we do, what another company does, and, maybe one seems to be better. I don't know, right?
Right.
So,
Exactly.
yeah, so that's that.